Fellowship Program. Advanced training in clinical nephrology, focused on the management of patients with primary and secondary glomerular diseases. It is structured as 3 modules, 20 credit each. Each module will be delivered over a 16-week period. This glomerular disease fellowship is open to physicians who are completing or having completed general nephrology training. Nephrology fellows, early and mid-career nephrologists are encouraged to apply. The GN student will be actively participating in a busy weekly glomerulonephritis and vasculitis scientific materials through participation in an ongoing program that includes lectures, MCQs, clinical case scenarios, journal clubs, academic webinars. Candidates completing the program will have developed sound principles and sufficient experience to manage all glomerular disorders. All activities and assignments will be monitored in the platform. Weekly qualitative assessment and evaluation will be performed based on engagement and activity in the program. The objectives of this program: we have designed the fellowship to advance the knowledge of trainees in the diagnosis and management of patients with all types of glomerular disease. The program is structured to enable trainees to complement but not substitute the education provided by the certified clinical nephrology training programs. At the end of the program, the participants are expected to submit abstracts to national and international meetings for presentation and to submit a manuscript for publication in a peer-reviewed journal. For registration and more information, visit worldkidneyacademy.org.
Welcome everyone to our GN Fellowship webinar. Today we are trying to wrap up after 10 months of intensive training and education. And today we have very special webinar. It's very interesting. We are going to discuss 2 of the most important topics in the GN. The first one is membranous nephropathy with introduction of new antigens and the new classification of membranous nephropathy. And the second topic will be the paradigm shift in podocytopathy. As you can see here, we have great speaker and great moderators of our webinar. We have our invited guest speaker, Professor Pierre Ronco, and we have Professor Giorgina Piccoli and Professor Afima Olasi and Professor Rasha Samir, who are going to moderate the session. Of course, we are honored to have Professor Pierre Ronco today. He is professor in Sorbonne, and he is the chief editor of the Kidney International journal. And I'm just giving you a brief introduction regarding our fellowship program, which is accredited 1-year online fellowship program that we started last year. And we are finishing next month, and our fellows are going to be graduate on October 26th. Then Professor Pierre Ronco will give his first talk about membranous nephropathy, and Professor Giorgina is going to lead the discussion. Then Professor Ronco again is going to give the second lecture about the new antibody discovery in podocytopathy. Then Professor Afima Olasi is going to lead the discussion. Then the closing remarks will be given by Professor Rasha Samir. So a great speaker, a great webinar today. I'm glad to have all of this international collaboration with the World Kidney Academy. And again, congrats for finishing Module 2 and Module 3 of our GN Fellowship. As you see, we started last year with Module 1 with an introduction about the basics and the principles of the GN. Then we focused on podocytopathy for a month and common glomulopathies. Then in Module 2, we were dedicated to the secondary GN, lupus nephritis, small vessel vasculitis, several weeks of nephropathology education, infection-related GN, GN in pregnancy and onconephrology, and of course, amyloidosis, MPGN, C3 glomulopathy. And we just finished Module 3 with hereditary nephritis, post-transplant GN, TMA, and the novel therapeutics and the pipelines intervention in different kind of GN. So congrats for all of you. We have more than 110 students who already received their Module 2 certificates, and they are going to receive their fellowship certificate in October 26 in a big celebration ceremony with the World Kidney Academy. So it has been a very long route, but very successful, and we have very good progress. And you will understand that this fellowship is going to positively impact your clinical practice, not only your training. Thank you for all of you. And the last announcement is we are restarting the critical care nephrology fellowship and renal replacement therapy fellowship next month. So I think this will be a very good opportunity for our fellows who are going to finish their GN training to join the new upcoming program. Again, please try to apply. And for all of our fellows, you can get 15% discount using the 24 fellows. So if you are a fellow with us in 2024, you can get 15% discount for any of the new program. And I'm going to stop by here, and I'm going to stop sharing my screen. Then we'll allow Professor Giorgina Piccoli to introduce Professor Pierre Ronco.
So thank you so much. And it's a pleasure being here with all the new friends. But the main reason why I am introducing Pierre Ronco is not just because he is very cultivated, not only because he is the well-known editor of Kidney International, but also because he's a fantastic person and he's a good friend. Pierre has actually discovered, was the one who changed the way we are approaching many glomerular diseases, shifting from the lesion to the reason. I will not add anything to what he says, but let me tell that he is also a humble, kind person, deeply loved by all his patients. So thank you, Pierre, for being with us, and the floor is yours.
Well, thank you very much, Giorgina, for your so kind introduction. I think you exaggerated a little bit, but you know, I am proud to be here this evening as a member, as a speaker in the World Kidney Academy. It's really an honor for me. So I selected two topics which are, in my opinion, very timely. The first is the new antigens and classification of membranous nephropathy. Will they change clinical practice? And the second relates to the discovery the rediscovery of anti-nephrin antibodies in patients with podocytopathies. Next slide, please. Nobody will deny that the discovery of Piccoli in 2019 has been paradigm shifting in the diagnosis and monitoring of membranous nephropathy. And this was followed by the development of diagnostic tests, first an indirect immunofluorescence test on the left, and then an analyzer to quantitate the circulating antibodies. And remarkably, these tests showed that anti-Piccoli antibodies were the most specific for membranous nephropathy, and their sensitivity was high. But in addition, as indicated in the lower panel, they were nicely correlated to disease activity, with the curve of anti-Piccoli antibodies in red decreasing before proteinuria, and conversely, the reappearance of antibodies announcing a relapse. So this is quite an important discovery. But next slide, next slide, please. About 20% of patients, at least, have a negative Piccoli serology. And the next major technological leap was achieved by this man. At the left-hand side of the picture, Sanchiv Sethi, a pathologist at Mayo Clinic, who combined laser microdissection of glomeruli, as shown in the slide, with mass spectrometry of trypsin digested proteins in patients with negative Piccoli antibodies. We collaborated with him, and all subsequent studies, including serum studies, confocal macroscopy, and validation cohorts, were recruited in Paris with the help of collaborators in Brussels and Rome. Can I have the next slide, please? So, will these new antigens, more than 15, will result in improved patients' care? And to illustrate my point, I would like to present the case of this Caucasian female, 61 years old, with a breast cancer, who declined treatment. She only took over-the-counter drug. She also had type 1 diabetes and MGUS. In July 2021, she developed a nephrotic syndrome with normal GFR, no hematuria, and the kidney biopsy showed membranous stage 1 with deposits of IgG1 and 4. It was negative for Piccoli and THSD7A staining, and other antigens at that time were not known and not tested. So the question is, what is the antigen in immune deposits, and what are the clinical consequences of its identification? So, thank you. The first antigen, not really an antigen, but a biomarker, because we have not yet identified antibodies. This is currently in progress, was exostosine 1 and 2, which is associated with 30% of lupus cases of membranous nephropathy with or without proliferation. And as you can see on the next slide, please, you can see the immunohistochemistry on the upper panels and the immunofluorescence in the lower panels from the same patient with where the deparaffinized kidney biopsies were stained with anti-X1, anti-exostosine 1, and anti-exostosine 2. And particularly in the lower panel, you can appreciate the beautiful granular fluorescence along the glomerulocapillary wall. Next slide, please. Unlike patients with Piccoli positive classical forms of membranous nephropathy, these patients were mostly females. They were young. They had nephrotic syndrome. 70% of them had some signs of autoimmunity, and 35% had a clinical diagnosis of lupus. 85% had IgA or IgM in addition to IgG, but not full house pattern. 73% had C1q deposits, and IgG1 was a prominent subclass deposited in place of IgG4, which is found in primary classical membranous nephropathy. By definition, Pierre was negative, and by electron microscopy, they had manifestations, they had signs of autoimmunity. Now, even more importantly, it was shown that the presence of exostosin 1 and 2 in the deposits shown here by dotted lines were associated with a better prognosis, as shown by these Kaplan-Meier curves in patients with pure class 5 membranous nephropathy. This is shown on the left-hand side, or with mixed class. This is shown on the right-hand side. And, we do not know yet was those patients with proliferative nephritis and class 5 with exostosin deposits are protected from from worse outcome to renal failure. So this is an important diagnostic, clinically speaking. Next slide, please. The next antigen that we identified was NEL1, which stands for neuroepidermal light growth factor 1. Initially, it was believed that NEL1 membranous nephropathy was a primary glomerular disease, but we will see that this hypothesis went wrong. Next slide, please. This slide shows that we use exactly the same approach, laser microdissection of glomeruli, followed by mass spectrometry, identification of NEL1 by mass spectrometry, confirmation of the presence of NEL1 deposits by immunohistochemistry. This is the central panel, and you can see that the nice confocal fluorescence of NEL1 and IgG in yellow. And finally, we are fortunate enough here to identify circulating anti-NEL1 antibodies that were correlated with activity of the disease. These were 34 patients. Next, Tiffany Casa, next slide, collected a larger cohort of 91 patients. And she made three important observations. First, the deposits were either segmental or global, but then they were incomplete, as you can see on the left-hand side. The major subclass were IgG1 and not IgG4. And more importantly, in 1/3 of the cases, the disease was associated with malignancy. And when the tumor was associated, was available, it stained positive for NEL1. Next slide, please. Then Rebecca Spain made the important observation that in some patients who were taking lipoic acid as an antioxidant for multiple sclerosis or pain linked, for instance, to diabetic neuropathy, the NEL1-associated membranous nephropathy, which developed in these patients, disappeared. I mean, entered remission after several weeks or months, which is quite extraordinary for membranous nephropathy. So lipoic acid was considered as a potential cause of NEL1 membranous nephropathy, and this was confirmed in many instances since then. But next slide. Even more extraordinary, NEL1 positive membranous nephropathy was shown to be associated with traditional indigenous medicine. This work was performed in India by Tiffany Casa, who analyzed 186 cases of membranous nephropathy. She stains the biopsy for Piccoli and NEL1, and she examined very carefully the medical records for traditional medicine use and for laboratory values. And it appeared that in patients taking traditional medicine use, 30% of membranous nephropathy were observed among these patients, and NEL1 positivity was found in 88% of the patients. So NEL1 is strongly associated with traditional medical use. while in the patient not taking traditional medicine use before the development of membranous nephropathy, that is 120 patients, NEL1 represented only 5% of the cases. So she asked why, and she discovered that in fact traditional indigenous medicine was contaminated by mercury. And recently we published an editorial in Kidney International showing that NEL1-associated membranous nephropathy developed in fairness cream to lighten the skin. So next slide, please. So since the discovery of neutral peptidase on the left in Paris in a subset of children with who are born with membranous nephropathy, you see that the number of antigens first increased linearly with P-Latoire, then we identified cationic BSA, bovine serum albumins, and TH87A was identified, and then the number of antigens increased exponentially thanks to the discovery, the technical discovery by Sanchez-Sethi. And as you can see, how times have changed. Now we have a cornucopia of antigens for membranous nephropathy. And this is summarized in the pie chart on the right-hand side, where you see that among the biopsies that are seen at Mayo, P-Latoire represents 55%, and it is immediately followed by NEL1 and exostosine 1, but the others are minor antigen, and the unknown are only 10%. And I bet my shoes that in 3 years from now, the 10% will be 0, and we will have an antigen for each membranous nephropathy case. So next slide, please. We had a meeting at the Mayo clinics in October 2022, and we asked the question, should we change the classification of membranous nephropathy between primary and secondary? And we thought that an antigen-based classification would be legitimate for 2 reasons. First, each antigen-associated membranous nephropathy has its own characters, including clinical setting, young age, association with autoimmune, etc. Pathology, I showed that deposits were different in NEL1-associated membranous nephropathy, where they were segmental, and there are other characteristics, and antigen conformation, since antibodies could recognize either the reduced or the unreduced form of the antigen. I don't have time to go into detail. And the second reason is that most antigens are preferentially associated with an underlying condition, be autoimmunity, cancer, medication, traditional medicine, which of course can lead to specific personalized treatment. And this is shown on the next slide. Thank you. Here, the new classification includes 2 steps. First, the identification of the antigen on the left, and second, the associated disease on the right. And the association are shown by color codes. For instance, NEL1, malignancy and drug, and mercury, CMAS3B, only pediatric patients. Autoimmune disease is associated with exostosine, NCAM1, TGFB R3, that I did not have time to detail. And the proposal was to change the terminology as follows. First, for the pathologist, MN. Second, indicate the antigen associated to NEL1. And then, when the cause is known, lipoic acid, for instance. Next slide, please. So this has changed the diagnostic algorithm of membranous nephropathy that was initially proposed by Mayo. On the left-hand side, you have the patients with a positive serology. Those patients do not need a kidney biopsy. I mean, the kidney biopsy is not mandatory because of the specificity of P-Latoire antibody, except, of course, if there is progressing kidney failure or unusual presentation. However, and this is the right-hand side, in the patients that are P-Latoire antibody negative, the key is the kidney biopsy. that should be stained for the various antigens that I mentioned. And here are the most frequent antigens. But wait a minute, next slide. We know that immunostaining is costly and time-consuming. So we have to be astute. And we have to consider that in those patients with a negative serology, PIRA2R and NEL1 represent more than 60% of PIRA2R negative patients. So we should start with staining with PIRA2R and NEL1. And then, if this is negative, staining should be oriented, driven by the suspected associated conditions. For instance, if you suspect an autoimmune disease, go to exostosine 1 and 2 staining. If you suspect malignancy, THD7A. If you suspect a polyneuropathy, go to contactin 1. If you suspect, if you have a stem cell transplantation, go to FAT1, etc. And of course, if there is no associated disease, then you have to stain many antigens. But this is rare. And finally, send the biopsy to Sanchez City to perform mass spectrometry. But again, in most cases, with PIRA2R and NEL1 staining, you can have a good solution. Next slide, please. Next. So I would like to come back to my unusual case of cancer-associated membranous nephropathy. You remember that I was, no, please go back. You remember that our question was, what is the antigen? And since December 2021, we had the possibility to stain for NEL1. So we performed NEL1 staining, and this is shown on the next slide. Next slide, please. And as you can see on the next slide, there is a beautiful NEL1 staining, while the patient was still nephrotic and were not treated for her cancer because she was taking over-the-counter drugs. And we suggested that perhaps she was taking lipoic acid because NEL1 is associated with lipoic acid in some patients. Next slide. Next slide. Bingo! She was taking alpha lipoic acid. We asked her to stop the over-the-counter medication, and the nephrotic syndrome went under remission. So what is the lesson? What is the take-home message? The combination of antigen identification and careful clinical observation and clinical sense are critical to appropriate diagnosis and treatment. And of course, not all cancer-associated membranous are paraneoplastic. So now I want to conclude. Please, next slide. I hope I've convinced you that antigen-driven personalized medicine is important because it allows to search for a cause, because it allows treatment monitoring based on serology. And I hope that the NEL1 serology will soon become available by Euroimmune. And also, it allows monitoring of the graph, as we did in a case of an adolescent with semaphorin 3B associated membranous nephropathy, but I don't have time to show you the details. So to conclude, next slide, please. Next slide. I think the discovery of all these antigens has induced a paradigm change in the understanding of membranous nephropathy, but also in patient care. It's not entomology, it's patients. We are caring the patients better. So the classification of membranous nephropathy should evolve from a binary condition, primary, secondary, to integrate the molecular dissection of the disease. We know that important challenges remain, but rare as a kidney disease where advances have been so fast with such an impact on diagnostic and monitoring. We hope that ELISAs and multiplex assay will soon be developed, as well as mass spectrometry in specialized centers. So next slide, please. This is to thank my collaborators, and particularly patients, the doctors from Mayo, and Anna Dobiek, my long-term collaborator, who participated in this fantastic adventure. Thank you so much for your attention. I hope I was not too long.
Thank you so much, Professor Ronco, for this fantastic presentation. It's not only the presentation, but also the discovery that you have made with your group and the Mayo group for the membranous nephropathy. Our great moderators today are Professor Giorgina Piccoli and Professor Ifima Olasi. And Dr. Giorgina is going to moderate the discussion of membranous nephropathy. Professor Giorgina graduated from University of Torino, Italy, and now she is the head of the nephrology division in Lehman's Hospital in France. And she is highly interested in the CKD progression and diet in CKD patients, women nephrology, green nephrology, and beyond. And also she is the chief editor of the Italian Journal of Nephrology, and she has been published a lot, and she is one of the experts in the different fields of the kidney diseases. I will let her to moderate the discussion. And also I have a very quick question for Professor Ronco. So the positive predictive value and the specificity for anti-BLAR 2 antibody and membranous nephropathy, I think, is very well studied. And now we don't even have to do a kidney biopsy for patients with classic presentation of membranous nephropathy with high titer of anti-BLAR 2 antibody. But does the anti-BLAR antibody specificity and the positive predictive value carry the same weight, same significance in both transplant membranous nephropathy recurrence as it does in de novo membranous nephropathy, or this is a different case scenario?
Oh, thank you very much for these are great questions. The pathophysiology of recurrent membranous nephropathy and de novo membranous nephropathy is completely different. I mean, the antigens are different. Most cases of recurrent membranous nephropathy are linked to PILA2R. And the question is, should we remove anti-PILA2R antibody before transplantation? I think it depends on the history of the patient. If the patient has recurred several times after transplantation owing to anti-PILA2R antibodies, then immunosuppressive treatment, and particularly anti-CD20, should be used before transplantation to eliminate the antibody. Now, de novo membranous nephropathy is very mysterious, but this week, with Sanchez Sedi at Mayo and researchers at Columbia, we identified the first antigen, which accounts for a percentage of de novo membranous nephropathy. This is FAT1. FAT1 is the same antigen as the one which is associated with hematopoietic stem cell transplantation associated with membranous nephropathy. And very interestingly, FAT1 membranous nephropathy is always associated with a rejection. So it's really interesting. It has just been published as a research letter in Kidney International. And I'm not sure it is available, but please look for it. And PILA2R is not involved.
Thank you so much, sir. Giorgina, please unmute yourself.
There are some questions in the talk. I think you excited the discovery of NEL1 and to put together some of the questions. I would like to ask you to comment on two issues. First, how long does it take once the offending agent has been withdrawn? How long does it take usually, or you expect to take, for remission? And how would you treat NEL1 positive membranous nephropathy in the absence of any evidence of malignancy? Thank you, Pierre.
Thank you, Georgie. Those are indeed great questions. So regarding NEL1, we have two offending agents that we know, and I think there are many, but we know about lipoic acid and we know about mercury. Mercury in traditional medicine and mercury in fairness cream that are not fair, as you can imagine. So the outcome is relatively short. Of course, it depends. It is variable from one patient to another, but in most cases, it takes weeks or a few months. And then proteinuria disappears totally. So I think in these cases where there is a clear cause for membranous nephropathy, one should only treat edema, adapt the diet, etc., but not give an anti-CD20 antibody. And in my opinion, there is no indication for rituximab. Most cases go spontaneously into remission rather quickly. Not in days, of course, but in weeks or a few months. Now, in the other patients, and I would like to generalize, in patients with the so-called rare antigens, the culprit is the B cells. So if you don't have a cause, you treat the B cell. And how to treat the B cell? With rituximab. And in refractory cases or less responsive cases, with super anti-CD20 like obinutuzumab. So, you know, the target is a B cell, and the most classical way to eradicate the B cells is to use anti-CD20. Of course, there are other approaches with anti-plasma cell antibody, and even CAR T cells have been used in refractory membranous nephropathy, but you know, this is the exception. So any membranous nephropathy is an autoimmune disease involving B cells. If you have an etiology, you get rid of the cause. If you don't have an etiology, you treat with an anti-B cell.
So let me go back to with, I don't know how many questions we have a right of asking, but this, I mean, another group of people is going back to the more common things, PLI2R positive disease. And they are, one is asking about the advantages of rituximab in the case of very high level of PLI2R antibodies and normal kidney function. And always in the same line, someone asks about an eventual role of plasmapheresis for recurrent membranous nephropathy post-transplant. We're always now focused more on PLI2R. And there is another very interesting question, always on PLI2R positive. How can we continue immunosuppression after complete remission? And if a patient is diagnosed on kidney biopsy and is anti-PLA2R negative in serum, what to do?
Mhm. Well, thank you, Georgina, and collaborators, I mean, in the chat. So there are several questions here. First, the level of anti-PLA2R at the diagnosis is not predictive of the response to rituximab, because the level of anti-PLA2R can fluctuate. And except in very aggressive forms, we recommend to wait for 3 months with symptomatic treatment before starting rituximab or any other immunosuppressive agent. So the level of PLA2R, I mean, should be monitored continuously. And what is important is the increase or the decrease. If PLA2R decreases, that's okay. If it increases, it's a reason, among others, to prescribe rituximab. Now, there was a question about should we continue immunosuppressive treatment when clinical remission is achieved? I think if clinical remission is achieved, there is no need to continue immunosuppressive treatment with rituximab, especially if the level of CD20 in the circulation is low. However, PLA2R antibody level should be continuously monitored. And of course, an increase in anti-PLA2R antibody level should lead to monitor proteinuria. But as in lupus, you don't treat serology, you treat the patients. That is proteinuria, okay? And the third question relates to what do you do when the biopsy is positive, the staining is positive, and serology is negative. There are 2 different cases. The first case is when the patient enters remission. So first, the serology disappears, and second, the staining will disappear, but it will take months. It will take months. Now, the other possibility is that the patient is very active, has a high level of antibodies, but you can't find the antibodies in the blood because they are captured in the glomerulus by the deposits. So how to differentiate between the 2 cases? By monitoring the level of circulating antibodies, which either will disappear definitely or will increase finally, because the glomerulus is saturated with the antibody.
So thank you, Pierre. We are asked to close this first part of the discussion, but may I tell you that there are many, many questions. That means that really everybody was really enthusiastic and curious, and maybe there will be some extra time in the end to answer. Thank you.
Thank you so much, Giorgina. And of course, after we finish the meeting, if we have leftover questions, we are going to reach out and try to answer these questions. And now I'm going to let Professor Ifeoma Olasi to lead the discussion and introduce the second lecture. Professor Ifeoma Olasi is professor of nephrology in Nigeria. and she is an international advisor of the Royal College of Physicians, London. She is also a member of the WHO Task Force in Organ Donation and Transplantation, and a member of various committees of the International Society of Nephrology, and she is executive committee of the ISN Advocacy Working Group, joint steering committee of the World Kidney Day, Advanced Clinical Trial Committee, International Network of CKD Cohort Studies. She's very active in the nephrology field. She's a very good representative of the African nephrologists and the international nephrology community. And I'm going to let her to introduce the second lecture and to lead the discussion.
Thank you very much, Amr. Good afternoon, good morning, good evening, everyone, because I believe we are so many of us joining from different places. My colleague, Professor Piccoli, has introduced Professor Ronco, and I want to say that I'm very happy to be in this space with all of you, Professor Ronco, Professor Piccoli, Professor El-Husseini, and I'm going to introduce the next talk from Professor Piccoli. I also want to add that the last one was very illuminating for me. I had a question in mind because I wanted to ask about, in my population, they use a lot of skin lightening creams and mercury. And I recall years back, I had looked at some of our patients who had nephrotic syndrome. A good number of them were using mercury-containing soaps and skin lightening creams. Anyway, that's apart. Let's move on to the next topic. The next topic is antinephrin antibodies, a paradigm shift in podocytopathies. This is very, very interesting in that we're beginning to know what is happening in podocytopathies. And of course, when you understand the pathophysiology and pathogenesis of a disease, you begin to think of therapeutic interventions. And Pierre Ronco is going to talk to us on this and give us a lot more light on what actually happens, the paradigm shift in podocytopathies. Thank you, Professor Ronco.
Well, thank you very much for your introduction. I'm really honored that to be chaired by you. And actually, I could have entitled my talk "The Death of the Loch Ness Monster," and you will see why. So recent discoveries, but not so recent, suggest that antinephrin antibodies may play some role in the pathogenesis of MCD, minimal change disease, and FSGS. And I will try to convince you that this is a major advance. But let's start with definitions, which are always very important. Minimal change disease is defined by the absence of visible alterations by light microscopy, and immunofluorescence is negative. That is the dogma. And of course, this is associated in electron microscopy with an effacement of food process, and the pattern is similar in children and adults. Of course, as you know, the disease is much more frequent in children, where it represents 70 to 90% of all cases of nephrotic syndrome after the age of 1 year, whereas in the adult, it's 10 to 15%. So in children, we do not perform a biopsy. Usually, the diagnosis mainly relies on the response to prednisone. That's why we call this disease steroid-sensitive nephrotic syndrome. However, we have to be cautious because MCD and SS and steroid-sensitive nephrotic syndrome, SSNS, are not entirely equal, although they are considered as defining the same disease. Why? Because there are steroid-resistant cases of MCD, and there are steroid-responsive cases of primary FSGS. The other podocytopathy is primary FSGS, always nephrotic, as compared to the other forms of FSGS linked, for instance, to nephron reduction. And it is characterized by diffuse effacement of food processes. And this is very important characteristics, as emphasized by Sanchez-Setti and Fernando Fervenza. Its relation with MCD remains controversial, notably in adults, and we will try to provide some light. So, since 50 years, we live on the Chaloup hypothesis, that is a dysregulation of T cells. Why? Because of the absence of IgG and complement in the glomeruli, because the remission after measles infection, which causes cell-mediated immunosuppression, because of response to treatments that suppress T cell-mediated immunity, because of the association with Hodgkin and non-Hodgkin lymphoma, and because of the lack of relapse of nephrotic syndrome when a graft is removed from a relapsing patient and placed in a patient with another nephropathy. But look, all these characteristics can be read differently and imply B cell. Indeed, the pathogenesis of mini-Munchausen disease remains a black box. It is partly due to the presence of soluble mediators that you have on the right, released by a dysregulated immune system, but still unknown. 50 years that they are unknown. However, the breakthrough was the efficacy of rituximab, which suggests that these soluble mediator shown on the left could be an antibody. And then this antibody could alter the integrity of the slit diaphragm, as shown in the middle panel, where nephrin and other related proteins play a very important role. Next slide, please. So we decided to approach this problem differently by a pangenomic studies that called GWAS. And we had first shown that the development of MCD in children was associated with alleles in HLA-DQ/DR loci that code for class 2 HLA class 2 HLA molecules. And we performed, as indicated on the previous slide, but that's okay, an international study that showed that not only HLA-DQ alleles were associated with the disease, but unexpectedly, nephrin, the gene coding for nephrin, and the gene coding for KIRL2. KIRL2 is NEF3, it's nephrin 3. It is very related to nephrin. And here you have all the alleles that are associated in nephrin and KIRL2 with the disease. And this finding led us to consider that exactly as in membranous nephropathy, the antibodies directed to nephrin could be involved in the pathogenesis of the disease. You remember that our GWAS in membranous nephropathy also showed HLA-DQ/DR alleles and PIRA2R. And here, PIRA2R is replaced by nephrin. Thank you. However, this is not a new concept because more than 30 years ago, in 1993, Japanese investigator had produced a monoclonal antibody that when injected into the rat, and this is shown on the left-hand side, induced a massive proteinuria with a disappearance of the antigen, which at that time was unknown. And as you can see, the antigen had a dusty fluorescence. And you will please remind this dusty fluorescence. And then when nephrin was cloned, David Salant and this Japanese investigator discovered that the antibody was directed to nephrin, and this is shown on the Western blot. So they missed nephrin, and fortunately, Trixazon, by different approach, identified nephrin, which is key to the function of the glomerular capillary wall. So antibodies to nephrin induce heavy proteinuria. Next slide, please. But also in patients, there is a redistribution of nephrin in patients with minimal change disease, and this is shown in the upper panel, and in the patients with primary FSGS in the lower left panel, whereas nephrin is normally expressed in IgA nephropathy, even nephrotic IgA nephropathy, where there are only minimal alterations of nephrin expression. So there is something here, which is very similar to the rat. So next slide. Next slide, please. So at this stage, the question is the redistribution of nephrin antibody mediated? And do anti-nephrin antibodies play a role in the pathogenesis of the disease? We have three evidences. First, the experimental evidence in the rat that I showed before. Second, very importantly, investigators have a short memory, but they should know that in patients with a Finnish type of nephrotic syndrome, where there are major mutations in the nephrin gene, the nephrotic syndrome recur not for genetic reasons, but because the immune system of the recipient sees the nephrin for the first time in the kidney graft. So this is alloimmunization, which proves that in humans, anti-nephrin antibodies are pathogenic. And finally, recently, a breakthrough paper was produced by the group of Astrid Vance, showing that anti-nephrin antibodies were correlated with disease activity in children of the Neptune cohort. And this is shown on the next slide. In this slide, Astrid Vance analyzed patients from their institution in Boston, Mass General, and the nephrotic syndrome, and patients from the Nephrotic Syndrome Study Network. They perform an ELISA for nephrin. They analyze the presence of IgG and nephrin in the biopsies, and they compare circulating anti-nephrin antibodies before and after treatment. And the results are shown on the right-hand side. And as you can see, 30% of the patients had nephrin antibodies, shown in blue, and the nephrin antibodies disappear at remission. But even more intriguingly, they found deposits of nephrin, shown on the left vignette, and of IgG colocalized, giving this yellow fluorescence together with synaptopody. So what we could not see before does exist. There are immunoglobulin deposits clustered with nephrin in patients with minimal change disease. And I will give you more information on that. And as you can see in the right lower panel, the anti-nephrin antibodies were only found in the circulation in the patients with nephrin deposits and IgG deposits in the biopsy. So next slide, please. This paper was very controversial because the pathology said, well, we can't find immunoglobulin deposits in the biopsy in patients with MCD. This is not true. Well, you can't see what you want, what you do not want to see. So we decided to do some more investigation in our patients. And here is a patient with minimal change disease, where you can see IgG deposits in the middle, nephrin deposit in the right, and a very nice colocalization of IgG and nephrin. And this patient also had IgM deposit, as can be seen in children, especially if they have some degree of mesangial proliferation. But look, then IgM and nephrin are not colocalized. IgG, because you don't have yellow fluorescence, only IgG and nephrin are colocalized. So we started to be convinced. And next slide, please. Next slide, please. Here, another case, where is a case, an adolescent with a primary FSGS, highly nephrotic. And you can see on the left, nephrin, in the middle, IgG, and very nice colocalization. And this is shown in the lower panel when you analyze quantitatively by laser cuts. This is the yellow lines, the fluorescence obtained with nephrin and with IgG. So next slide. We also wanted to detect circulating anti-nephrin antibodies by a different approach as the one used by Astrid Vance. So we perform Western blot analysis where we electrophoresed nephrin, recombinant nephrin, and we reveal the blot with the serum from patients with various forms of nephrotic syndrome. And you can see, this is the upper panel, that antibodies to nephrin were detected in patients with infrequently relapsing nephrotic syndrome, resistant nephrotic syndrome, steroid-dependent nephrotic syndrome, and again, infrequently relapsing nephrotic syndrome. And you can see in the lower panel that the antibodies that were detected at onset either decreased or disappeared in remission. So now we were convinced that Astrid Vance was right. And finally, this is not surprising because this was already demonstrated in the literature 30 years ago. So next slide, please. Next slide. We decided to to establish an international cohort that was coordinated by Toby Huber in Hamburg. This cohort included more than 360 patients, 2 adult cohorts from Hamburg and Bari in Italy, and 2 pediatric cohorts in Rome and in Paris. And this was recently published in the New England Journal of Medicine during the meeting of the ERA in Stockholm. And the next slide shows the prevalence by immunoprecipitation that was set up by investigators in Hamburg of anti-nephrin antibodies in patients. In the upper panel, panel A, you have the result of the Western blot after immunoprecipitation. In patients with MCD, 2 were positive. In patients with primary FSGS, 1 was positive, the controls were negative. But the most important is panel B. On the left, the adult, on the right, the children. And look at the red bars. The prevalence of anti-nephrin antibodies was more than 40% in adults with MCD and about 10% in the patients with primary FSGS, and almost 0 in all other cases. Now, if you look at the nephrotic patients, then the prevalence increases to 60% with MCD and to 70% in the patients who were naive that did not receive immunosuppressive treatment. Now, on the right-hand side, this is even more spectacular in children, where you have a prevalence of 50% in the whole population, but it increases to almost 80% in the patients who are nephrotic and 90% in the patients that are naive of treatment and nephrotic. And finally, the lower panel shows that in patients with anti-nephrin antibodies, proteinuria was higher. This is on the left. Serum albumin is lower. Serum cholesterol is higher, and GFR is the same. So now, next slide. The immunoprecipitation, the investigators wanted to know whether there was a correlation between the presence or absence of anti-nephrin antibody and the level of proteinuria. You can see that for anti-nephrin, positivity is shown by red, and negativity by blue. And for protein, there is a gradient from blue to red or dark pink, depending on the level of proteinuria. Now focus on the heat map located on the left-hand side. This shows in 18 different patients that were followed for a period from 1 month to 53 months, a correlation between the status of antinephrin, this is the upper part of each square, and the level of proteinuria. And this is very visual. Blue is blue, blue goes with blue, red goes with red. So there is an almost perfect correlation between the status, the presence of antibodies, and the level, the presence and the level of proteinuria. And on the right-hand side, you have the heat map for the kids, and almost the same, but the follow-up is shorter, except in the first 2 patients where you have patients that have antinephrin antibodies, and yet they do not have proteinuria, but these were multi-relapsing patients. Well, all in all, there is a very nice correlation between the presence of antinephrin antibodies and activity of the disease measured by proteinuria. Next slide, please. Now, the immunoprecipitation was made quantitative by adding an ELISA step. This is what we call the hybrid test. And you have in the left upper panel the level of antibodies that were measured in patients with MCD or primary FSGS expressed in reference unit per ml. And you can see that the controls, membranous nephropathy, LC controls were negative. Now there is a Spearman correlation, so shows a relatively good correlation between antinephrin antibodies and level of proteinuria. But even more interesting is the correlation with rituximab treatment. In the middle panel, you have a patient multi-relapsing, treated several times by rituximab at each relapse. And proteinuria is in black, and the antibody is in red, shows how the correlation is nice. And the same in the lower panels, where you have a patient with MCD on the left and patient with FSGS on the right, which was treated by rituximab. And you have a very nice correlation again between antibody and the proteinuria. Next slide, please. So the problem is that the immunoprecipitation hybrid test is a bit tedious and cannot be transferred to routine. So we have established a new ELISA, which is a direct ELISA where the plates are directly coated with recombinant nephrin. And here as a result of, in the left in children and on the right in adults. In children, most of the patients under the threshold, under the cutoff, are patients that are treated. Above the cutoff, there are patients that are active. And on the right-hand side, you have patients with primary FSGS. 8 of 12 are positive, while the controls are negative. And among these patients, there are patients from Giorgina department in Le Mans. Next slide, please. So finally, can antinephrin antibodies predict relapse, recurrence in patients with primary FSGS that are refractory to other treatment? So this Japanese group collected 14 patients with presumed primary FSGS, 11 recurred, 3 did not recur. And as you can see on the right-hand side, the 11 patients who recurred had antinephrin antibodies before transplantation, and they disappeared after transplantation, and the controls were negative. But even more exciting is that they performed the kidney biopsy 1 hour after transplantation. And of course, they had a consent for that. And you can see that 1 hour after transplantation, you have IgG and nephrin that are co-deposited in the graft. So this is another evidence for the responsibility of antinephrin antibodies in the recurrence. But of course, this has to be confirmed in other studies, and in press, in Kidney International, you have an American studies showing that antinephrin antibodies predict recurrence after transplantation in patients with refractory FSGS. So next slide. Next slide, please. Can I have the next slide, please? So in conclusion, the field is moving at last. No need to look for the Loch Ness any longer. Antinephrin antibodies correlated with disease activity has been definitely confirmed in keeping with the beneficial effects of anti-CD20. They represent the first biomarker available, and we hope the development and commercialization of a user-friendly ELISA very soon. Now, next slide, and conclusion. Many questions remain. We are just at the beginning. We are learning. Can antinephrin antibodies predict steroid dependence and steroid resistance? We don't know. Is there a correlation between level of antibodies and outcome? We don't know. Can they predict relapse? We don't know. What are the antigenic targets in antinephrin negative patients, particularly those with primary FSGS? We don't know. Are there other permeability factors than antibodies? I don't believe so. So thank you very much for your attention.
Thank you very much, Professor Ronco. You have indeed shown why you are known all over the world for what you do. Thank you so much for illuminating us so much. We have so many questions here, but I understand our time is short, but we can take some questions. The first question asks, is antinephrin antibody specific to MCD and FSGS, or is it an indication of podocyte injury?
Well, as yet, the investigators have not found antinephrin antibodies in other situations, or they are exceptional. There is one exception that is not reported in the paper in the New England Journal of Medicine, and which will be the topic of a new paper. The exception is genetic FSGS. A substantial proportion of genetic FSGS linked to nephrin or to podocyte alteration are associated with antinephrin antibodies. In this case, it might well be that the genetic defect of the podocyte induces expression of nephrin at the surface of the podocyte and induces immunization. In the same way, if you like, as alloimmunization in patients with Finnish type nephrotic syndrome, where the lymphoid system of the recipient sees the foreign protein for the first time. But of course, these are only 360 patients. We need to investigate more and more patients, and we need to have very good assays. The ELISA is very controversial. Some investigators say that it doesn't work. It works in our hand. It works in Astrid Vance. It works in the Chinese hands. We have, to test the same sera with different assays to make sure of the specificity of this assay. I mean, the technical problems are not completely solved yet.
Thank you very much. We still have many more questions. This one asks if antinephrin antibody is reflexive of the disease activity, recurrence, and response to medication.
Generally, yes. I showed these heat map. You remember with the
Yes.
with the red with the red, blue for the status, and the pink and blue for the proteinuria. So usually, in most cases, there is a good correlation, very good correlation. I mean, these sera were tested blinded. I provided the pediatric cohorts from Rome and from Paris to Hamburg. These cohorts were coded. They did not know. And when, the codes were revealed, then we were really impressed by the correlation with the clinics. And I also rapidly showed the effect of rituximab, in the two patients that were shown at the lower part of the slide. And there was a very nice correlation. But two patients are not enough, of course. So as I said, we are learning. So I don't want to make definitive conclusions. The thing for Predatoire, Predatoire 2009. We are in 2023, 2024. 15 years later, we do not know all, including for correlation.
Since we are talking about treatment, this asks if antinephrine higher levels would need higher doses of steroid and rituximab, or levels don't affect treatment selection.
That we do not know yet. We have to do the study.
Yes, yeah, for sure. And then this asks if Hayman nephritis rat model for megalene is same as the anti-nephrin nephrotic syndrome.
No, megalene model is for membranous nephropathy. So for the nephrin model, Nicolas Thomas in Hamburg established a nephrin model with transgenic podocytes expressing human nephrin in the podocyte. And this model works with mouse antinephrin. And I was told, but it has not been published, that there is a species where when you infuse the human antinephrin antibodies, you induce a proteinuria. But coming back to the past, Shimizu and Salant, they had a very good model. I mean, when they infused MAB516 to the rat, which is directed to nephrin, they induced massive proteinuria.
Okay, can we take this one? Are we out of time? Antinephrin prevalence is about 80% in children and 30% in adults. And it's asking why. Can you tell us why it is different for children and adults?
Yes, I don't have definitive answer, but children are often naive of treatment.
Yeah.
While adults, most of them have received some treatment, either steroids or an infusion of Ritux or whatever. And I have a good argument for that. If you look at the prevalence of antinephrine in the children's cohort from Neptune, the prevalence was only 30%. But now Astrid Vance say, well, I know the answer. Most of these patients were treated. So if you treat the patient, you decrease the prevalence of antinephrin antibodies. So to determine the true prevalence of antibodies, you need to have naive patients. And that's explained, in my opinion, the difference between adult and children.
Okay, thank you.
Thank you so much. For the sake of the time, Professor Afimia, thank you so much for moderating the discussion. And I think it's a time now. Thank you again, Professor Ronco, and thank you for Professor Giorgina. I think I'm just going to introduce the hero behind all of this, our meeting organizer, and the one who worked behind the scene to make this happen. Dr. Rasha Shimis. She is the organizer of this meeting, and she invited Professor Pierre Ronco and the moderator as well. And she's going to give us the conclusion remarks right now. Thank you so much.
Thank you so much, Dr. Amr, and thank you everyone for joining us today for this insightful webinar. I'm so grateful and would like to thank Professor Ronco, Professor Piccoli, and Professor Relasi for accepting our invitation and for their insightful contribution for this today's webinar. Professor Ronco, we are so grateful, and we all owe you as nephrologists the discovery of new agents that changed the landscape of membranous nephropathy and your great contribution to the pathogenesis of glomerulonephritis. For the sake of time, I'm gonna thank everyone for their participation, and we're looking forward to see you again in future events. And thank you. Have a great day.
Thank you. Can I
Thank you so much.
Can I add something? I can continue to address questions by mail. So please,
thank you. That would be very nice.
Email your questions and I will answer.
Thank you so much.
I think another thing is some people had issues with the slides. Is it possible to share slides for them? Yeah.
You can. You're
I think Professor El-Husseini, you can do that, because I saw some people saying that they couldn't see the slides. So if we could share it, I'm sure they would love that. Yes.
No problem.
Thank you so much, Professor Ronco. I learned a whole lot. So I'm gonna see if I'm gonna look at our patients who use bleaching cream and look for antinephrin antibodies. Thank you so much.
Thank you.
Thank you, everyone.
I did enjoy. Thank you.
Thank you, Rasha, for inviting me. Thank you.
Thank you.
Rasha, thank you so much. Bye, Professor
Bye.
El-Husseini. Bye, everyone.
Bye.
Thank you.
Thank you.
Thank you.